Welcome back to Mapping Healthcare on KDRT 95.7 FM in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Mr. Miller is 82 years old. He lives with heart failure and diabetes, and he's managing a dozen different pills every day. After a week in the hospital for an infection, he's ready to go home. But the transition is a bit of a medication maze. His hospital doctor stopped one of his blood pressure pills because his blood pressure was low, started him on a new antibiotic, and switched his indigestion pill to a different brand because that's what the hospital pharmacy had in stock. By the time Mr. Miller gets home, he finds that the paperwork he was given at the hospital is confusing. He ends up taking both his old blood pressure pill and the new one, while completely missing the antibiotic. Over half of patients face at least one of these medication discrepancies when they move between healthcare settings. This gets more problematic for people who take 5 or more medications. The more meds you add, the risk of their interacting with each other grows exponentially. If you take 2 meds, the risk is small. If you take 10, the risk of an adverse event is almost 100%. And some medications are more dangerous than others. If you mess up the dose on a multivitamin, it's likely nothing happens. But if you mess up the dose on insulin, that's life-threatening right away. On a blood thinner, too much, you bleed out. Too little, you get a clot. Opioids, seizure medications, these drugs have a narrow therapeutic index. This means that the difference between a cure and a poison is a very small margin. In today's episode of Mapping Healthcare, we're talking about a process called medication reconciliation, or MedRec for short. While it may sound like a dry administrative task, it's actually a safety net. The gold standard for this process is what's called the best possible medication history. This isn't just looking at a computer screen. It involves a clinician sitting down with a patient, calling their community pharmacy, and looking at their actual pill bottles to figure out what they're really taking. Like medication detective work. This wasn't always a priority. Back in 2005, the Joint Commission in the United States made medication reconciliation a national patient safety goal, recognizing that poor communication at transition points was responsible for up to half of all medication errors. Since then, the process has evolved from simply matching medication lists to a sophisticated pharmacist-led intervention designed to catch errors before they reach the patient. When pharmacists lead this charge, they find significantly more medication errors, sometimes a third more than physicians or nurses, simply because they have the specialized expertise to spot the gaps. While pharmacists are absolute pros at reducing medication discrepancies, it's difficult to prove that this alone stops all medication problems, because health is so complex. But for high-risk patients like Mr. Miller, having a pharmacist double-check that list is often the difference between a safe recovery and a dangerous adverse drug event. Since pharmacists are expensive and busy, who else can do this? Pharmacy technicians or even trained pharmacy students can be highly effective, sometimes even more accurate than doctors or nurses at gathering medication history. This frees up the pharmacist to do high-level clinical work. It's a smart use of resources, and it turns this medication detective work into a team sport. Our guest in today's episode of Mapping Healthcare is Linda Graudins, who led the medication safety program at Alfred Health in Melbourne, Australia, and has been a hospital pharmacist for over 40 years. The views expressed on the show are mine and those of my guest. So Linda, welcome to Mapping Healthcare.
Well, thank you very much for inviting me. I'm very excited to talk about medication safety, especially on the global issues as well.
And today we are focusing on this concept called medication reconciliation, which is really critical to medication safety. So that's what we will be talking about today. And this is really pertinent to your expertise because you were the medication safety senior pharmacist and lead of the medication safety program at Alfred Health in Melbourne, Australia. And I've been a hospital pharmacist for over 40 years. You are also the regional editor of the International Journal for Quality in Healthcare. So, to start us off, tell us a little bit about your career journey to where you are now.
Well, as you mentioned, I have been a pharmacist for a long time, 40 years. And I started actually my journey in Sydney University, where I graduated and spent some time in internship and various clinical pharmacy roles in hospitals mainly, although I did touch on some community work as well. I was very interested in hospital pharmacy, so I did some postgraduate diplomas in pharmacoepidemiology and specialising in hospital pharmacy. Pharmacy is very interesting. It leads to a very wide variety of options. And we were living in Boston for 2 years, and I was very lucky to get a position at the New England Medical Centre, where I worked there for a year. Again, brought a lot of expertise from that position back to Sydney, where I worked as a formulary manager in a major hospital. My research interests led me to join a research team with Dr. Madeline Gazarian in a hospital actually next door to our adult hospital, and it was a Sydney Children's Hospital. And the project was very up my alley about decreasing prescribing errors and adverse drug events in children. It was a funded project, and it actually led to an establishment of the medication safety and quality use of medicines pharmacy position, which was a new position at the Sydney Children's Hospital and one of the first ones of its kind in New South Wales. Very exciting times. I stayed there for several years in that position, developing it with Madeline, and left to go to Melbourne, where I am at the moment with the family. And again, lucky enough to take up the opportunity and the challenge of joining the pharmacy department team at Alfred Health. So Alfred Health is a network of 3 large hospitals and a outpatient infectious diseases clinic. And I joined the medication safety team as a senior pharmacist, and then became the lead pharmacist for medication safety at the hospital. Had a lot of opportunities to lead the hospital's accreditation in medication safety standard, a lot of education of staff, medical and nursing and pharmacy in medication safety, and doing some research work in adverse drug reactions, which is really my passion project.
That's great. And so it's sort of this, well-rounded look at various aspects of pharmacy and the care that pharmacists provide that you've developed over the last 4 decades. And you work on promoting medication safety globally. And today we're talking about the situation of people being on multiple medications at one time, sometimes as many as 5 or 10 medications at a time. And the reason we may be seeing this these days is as people age, they develop more health issues. So diabetes, high blood pressure, heart disease, or arthritis. So they end up being on more and more medications at one time. So how does the role of pharmacists in managing high-risk patients on multiple medications differ or vary across regions such as North America, Europe, and Asia compared to Australia?
Yeah, it's been really interesting as the one of the deputy editors of the International Journal. I get to read a lot of manuscripts from all over the place. And last year, I spent 6 months overseas and actually had the chance to visit some hospital pharmacies and pharmacists and give some lectures as well in Riga. And it does vary from place to place. But the interesting thing that I found was that pharmacists, at least, we all speak the same language and we understand about medication safety. Really depends on the resources available. Really, a lot of it's from legislation and budgeting in this area. So not from clinical knowledge, but actually these other areas that we have less control over. So from a pharmacist point of view, I noticed availability of pharmacy services is really one of the major determinants of pharmacists being able to carry out medication reviews and look into patients at high risk.
Let's now talk about the Australian experience. Generally, when I look at studies out there, about 1 in 5 adults takes 5 or more prescription medications at a time. And so this obviously increases people's risk of medication side effects and interaction. And medication reconciliation, it's a process where healthcare professionals like pharmacists create the most accurate, up-to-date lists of all patient medications, including doses and frequency, and then they compare it against new orders to identify and resolve things like omissions or duplications or possible interactions. So this process is especially important during this period of transitions of care, such as hospital admissions or when people are sent home from the hospital. And it's important to prevent errors and side effects. So medication reconciliation is really critical, and we work on that in the United States, but the processes for that vary a lot. So what's an effective model for medication reconciliation that you've seen in Australia or, have worked in your setting?
At Alfred Health, we have medication reconciliation is very core business for pharmacists. We love to have the face-to-face interactions. We want the patient to be part of this interaction rather than just looking at a laptop and having a look at what the medication list is. So we found that it's actually real reconciliation, because what's in the medication list, as you probably know, is not necessarily what the patient takes. So they might come in with a bag of medication or a long list and say, well, I don't really take that tablet because, it disagrees with me, or I get a rash, or I don't want the doctor to know, but I'll tell you. So we love the face-to-face interaction. We did a project with the WHO High Five project several years ago, which was introducing standards of practice of medication reconciliation and how effective that was across Australia. And that project actually found that it varies. Australia is a very big country, just like the USA. And it varies from state to state and from hospital to hospital, again, depending on resources. So the Alfred is very well resourced. We have 7-day-a-week pharmacy service, clinical pharmacy service up in the wards. And what we found is best is that the pharmacists are attached to each medical and surgical team. So rather than sitting in a pharmacy department, pharmacists go on the ward rounds. They know what the problems are. They know what the medical staff is discussing and what they are telling the patients. So they're really on the front foot already. The doctors expect the medication list to be written by the pharmacist within 24 hours of the patient admission. And I've worked in the emergency department at the Alfred, and they often write a record, patient to be admitted by pharmacists, so we know what the medications are about. I think that would be the ideal scenario for everyone to do, because the pharmacists, as you mentioned, are the medication management experts in that area, frees up other staff to do what they're experts in, for example, diagnosis, administrations of medicines, and so on. When we're talking about multiple medications, of course, a lot of patients need those multiple medications. It's not always a bad thing. And in fact, Alfred Health has transplant patients. They need a lot of medications to keep them alive and keep the transplants viable. So obviously, those patients require that. Post-cardiac infarction often need triple therapy, antiplatelet therapy. So it's not always a bad thing, and it's just a matter of making sure the patient knows how to take them, making sure the patient understands the importance of taking their multiple medications, and decreasing adverse effects, so that we can give alternative medications. If they're allergic to one particular type of antibiotic, we can suggest another antibiotic for that particular patient and infection. So it's part of being the team, part of the patient being in the team as well, and the patient understanding what role they're playing with their own medication management.
So, Linda, our last episode of Mapping Healthcare was actually also set in Australia. I had spoken to a physician in Australia who runs hospital at home programs there. And clearly, there is an important role that pharmacists play in these programs. So perhaps we could talk about a little bit now about the role of pharmacists in hospital at home programs and how we can work to keep patients outside the hospital healthy.
We also have a team looking at what's called Better at Home, because we want to keep patients out of the hospital if possible, especially with elderly patients. And so we have pharmacists going into the homes, looking at what is actually happening there, making sure the patients can inject their insulins, and they don't have old medications that they're still taking or borrowed from the next door neighbour or their wife or husband. So I think that is where a lot of pharmacy work is going to be happening, and a lot of our work in general in the hospital is keeping patients away from the hospital so they can be treated in their own houses, their own homes.
So, older patients are much more likely to develop side effects to medications because their kidney or their liver function goes down with age, and our bodies are less able to process and filter out some of these medications. And there's clinical guidance these days from professional societies to help us taper or stop prescription drugs that are no longer needed or that can cause side effects for patients. But one barrier is that many clinicians, including frontline primary care clinicians like me, there's overpacked schedules with no time set aside for this important task of medication reconciliation, or we don't always know how and when to safely help patients come off drugs. So, in your mind, how does technology such as electronic health records, e-prescribing, or telepharmacy shape pharmacists' abilities to support medication reconciliation in your setting?
Yeah, that's the way we're going. Obviously, with all our technology and digital health, is very important to help us manage medications now which are becoming more and more complex, as you mentioned. There's a prescribing cascade. One specialist will prescribe one thing. Patient might have multiple comorbidities. They go to another specialist. They put on something else, and this is all adding up to a lot of medications for the patient. What we did at Alfred Health and in Australia in general, in the last decade or so, we've introduced a lot of electronic medication records. And all our medication management is now integrated with smart pumps and a lot of prescribing support in the medication record. We also have some statewide and national electronic assistance, I suppose you could say. We've got something called Safe Script, which actually started in Victoria in 2019, I think it was. It's now expanding nationally. So this is a real-time data about prescription of narcotics, including codeine, benzodiazepines, quetiapine, and recently added tramadol and the gabapentinoids. And actually, doctors and pharmacists are mandated to check this before prescribing these drugs in certain situations. And in the hospital, we have access to Safe Script as well as part of our medication management program. We can click on a link which takes us to the patient's information. And so we can see what benzodiazepines they've been prescribed, how often alerts come up. That has been shown to decrease drug-related deaths since its introduction. The other thing we have nationally is called My Health Record, again, an electronic system, which is, again, integrated into our electronic management at the hospital. It's a national medication record that GPs, hospitals can upload discharge summaries and notes into the record, adverse drug reactions, any other such records, and we can view for our patients. Now, it's not ideal, rubbish in, rubbish out, as a lot of electronics records are, but it is better than what we had, and it is a national record. So if patients go from one state to a next, we can have a look what they've had. Patients can opt out if there's an issue of privacy or concerns. So those nationally, because patients move around, of course, we can't just rely on our own hospital information and medical record. It's very important to have a national sort of system, and that's becoming more and more obvious with the rollout of the national medication record, that will soon not just be able to see Safe Script medications, but all patients' medications. So that'll be a real boon to medication reconciliation, whereas now we're ringing the hospital, other hospitals, or we're ringing the community pharmacy where the patient goes, trying to get a hold of the GP. We might be able to see it all in one central spot. So that's fantastic. Australia, as I've mentioned, is a big place. So for American listeners, you might imagine flying from Florida to California. So that would be from flying where I am in Melbourne to the other side of Western Australia, Perth. It's about the same distance. So quite a lot of long distance, and everyone lives, most people, 80% I think or so, live at the coast. So there's a vast inland where there's small communities, small towns, very hard to reach. very hard to get clinicians to work there, specialists, especially pharmacists. So we do rely a lot on telehealth, especially since COVID. It's been very well developed. And pharmacists are doing their medication reconciliation, their follow-up of patients using telehealth in these communities. And for example, the Northern Territory, they've got 35% of their population's Indigenous. So again, another layer of difficulty in reaching those people, medication reconciliation, talking to them about what their beliefs are about medications. It's a completely different area of medication reconciliation and specialty area in pharmacy.
Yeah, so that's great examples of using technology to reach rural and remote communities, trying to make sure that we have records that are untethered to specific hospitals that, follow a patient around regardless of where they seek care. So lots of ways to make sure medication safety works for our patients. And, I've been trying really hard not to use the P word here. You've chatted a little bit about the fact that you hate the word polypharmacy. And, basically that's being on multiple medications at one time. And some experts use that term for that scenario, polypharmacy. And it's really common in older people and children, particularly those with chronic conditions like epilepsy or mental health issues. So tell me about why you don't like that word and what we should be using instead.
Well, pharmacists are very, very fussy people, and especially about their terminology. I actually looked up where polypharmacy comes from. It's from ancient Greek, and pharmacy just means administration of medicine. So there we have it. And that term apparently has been in use for several hundred years, which I didn't know. But these days, we'd like to be a bit more modern. And it does have, as I mentioned before, it does have a negative connotation that we've got to decrease polypharmacy. It's a bad thing. And with relation to that, it sounds that pharmacy is a bad thing. So we don't really, I know it's WHO, with all respect, uses that term, and it is an official term. How about we start changing it to maybe multi-medicine or polyprescribing? Because really it's the pharmacy doesn't initiate the medicine, does it? It dispenses it, and it's not usually about drug seekers or people going from pharmacy to pharmacy and using a lot of pharmacies or pharmacists. It's about the medications being prescribed in the first place. So that's it's a call for modernisation of the term, and let's start now.
All right, so let's do that. Change our medical dictionaries to include terms that are more suitable to the current situation of trying to make sure medications work for patients in the ways that they need to. And, as you were talking about using technology to reach patients in, those rural and remote communities that you have in Australia and that we have in the United States as well, one thought that crossed my mind is that it's really a way to increase access to care from our pharmacists and to reduce some of those disparities that we see in the United States as well. But tell us a little bit about what other strategies we use to make sure that the playing field is level for people who have trouble accessing pharmacy services.
I suppose I have to describe a little bit about the remuneration of medications, which is quite a different system than the States. So we do have a national PBS, which is a pharmaceutical benefits scheme, which the government subsidises medications so that patients are not paying more than a certain amount, which is quite different, of course, to your system in the States, which is a lot of private insurance. Hospitals are state-run, so their budget is state. So there's always this balance of state-run hospitals dispensing national supported medications and so on. But I think we're very lucky here. We have this system, and it is more affordable than most places in the world.
Yeah, and so clearly, Linda, you've played a leadership role in much of the work that pharmacists do in your area, and you continue to play that role working globally in this area. Let's now move from work to what you might do after work, right? And so you live in a gorgeous part of the world. You live in the Australian state of Victoria, in Melbourne. Tell us about a couple of places or activities in Victoria or in your city of Melbourne that a person new to the state should check out when they're not working.
Well, Melbourne's known as the sports capital of Australia. People from other places might dispute that. If you're into tennis, we've just finished the Australian Open tennis championships. And then we, of course, have cricket. And then we have Australian League Football, AFL. Melbourneites are crazy about football. Everyone has to have their own team. The city goes in various colours when the games are on. So that's the sports. Of course, we're known as the coffee capital of Australia, cafes everywhere. But if you're a nature lover, we have penguins in Phillip Island. We've got the Great Ocean Road, got lots of coastline and lots of bushwalking, koala watching and wine tasting.
Talking about team sports, medicine as well requires teamwork. And so as a physician, I strongly appreciate the contributions and the hard work of my pharmacy colleagues that help us make our healthcare clinical team really strong and make sure that we deliver high quality care to our patients. So with that, Linda, I'd like to thank you for being on Mapping Healthcare and for sharing your expertise, years of expertise as a pharmacist with us here today. Thank you so much.
Thank you for the opportunity. It was great.
So that was pharmacist Linda Graudins telling us about why medication reconciliation isn't just checking boxes on a clipboard. In fact, sometimes it's actually more like high-stakes detective work. We aren't just talking about filling forms. We're talking about making sure transitions in care are smooth. Making sure people are safe during dangerous moments during their journey through the healthcare system. The point when they're admitted to a hospital or moved from the ICU to a general ward, or go home from the hospital. Because that's where the information chain breaks. 56% of patients are at risk of having one or more medication discrepancies during these transitions. That's more than half. That's a coin flip. Heads, you get the right meds. Tails, something goes wrong. One thing I was thinking about is why hasn't technology fixed this yet? You may assume that when you walk into a doctor's office, she looks at a computer screen, pulls up your medical record, and sees everything you're taking. It's all there in the cloud, right? But that's a big misconception. The computer most likely knows only what was prescribed within that specific system. It doesn't know what a specialist in the next town prescribed. It doesn't know what you bought in the pharmacy down the street. It certainly doesn't know what you decided to stop taking because it gave you an upset stomach. People may list their prescription pills, but they may not mention the ibuprofen they take several times a day for their back pain. Or they won't mention the St. John's wort they bought at the health food store. Or the prescription pill they cut in half to save money. So as we wrap this episode up, here are some of my big takeaways. Focus on people at high risk of medication problems. Health systems don't always have the resources to do an in-depth medication history for everyone. So in that case, prioritize patients who are elderly or who have complex medical conditions, those who take more than 5 medications, or are on high-risk meds like blood thinners or insulin. Second, the best possible medication history is a conversation, not just a list. An accurate history requires at least 2 sources of information, with the patient or the caregiver being the most important source to uncover herbal remedies or over-the-counter meds that aren't in the electronic record. And finally, pharmacists and pharmacy techs are VIPs on the healthcare team. They're at the front lines managing medications, keeping those potentially dangerous transitions from home to hospital and back to your home smooth and safe. Thanks for tuning in. This was your host, Dr. Sheikh. You were listening to Mapping Healthcare on KDRT 95.7 FM. Connect with the show on Instagram at Mapping Healthcare if you'd like to share your thoughts and ideas for future episodes or guests. You can hear Mapping Healthcare around the world anytime on kdrt.org and wherever you get your podcasts.